We go beyond the journal articles and into the laboratory and the field as scientists share their discoveries in a way everyone can understand. It's science explained. You're listening to Science Sound Off on Texas A&M Health Talk. Welcome to Science Sound Off. I'm Christina Sumners.
And I'm Tim Schnettler.
Our guest today is Dr. Joe Rutkowski, an assistant professor of medical physiology at Texas A&M College of Medicine. Welcome, Dr. Rutkowski.
Thank you for having me.
So you and some of your fellow researchers have recently received a couple of major grants to study the interaction of renal lymphatics and blood pressure. Could you tell me a little bit about what you guys are up to?
So the lymphatic system is really underappreciated by most in the medical field. It closes the circulatory loop, and it's responsible for the clearance of fluid, macromolecules, and immune cells from peripheral tissues and bringing them back into central circulation. As such, it plays a critical role in inflammation and immunity. And work over the last decade in many labs has identified that hypertension is in part a disease of chronic inflammation in the kidney. And so we hypothesized that changes in the kidney's lymphatic architecture would play a role in regulating blood pressure.
Interesting. So you study the renal lymphatic system, so that's the kidneys. Why are kidneys, let's just kind of go back to basics, why are kidneys important in the body?
Well, kidneys are you can think of them as the filter organ of the body in a sense, in that they're filtering unwanted metabolic waste products from your blood, also drugs and other things that are going out through your urine. As such, they help to regulate fluid balance in the body. And so they are actually the organ that probably is most responsible for maintaining blood pressure, in the sense that they're maintaining the blood volume, as well as secreting a host of hormones that regulate vascular tone and help to regulate blood pressure that way as well. So common anti-hypertension medications are just simply like diuretics to reduce your fluid volume so that you urinate more. So it reduces your blood volume, your blood pressure goes down.
So how can high blood pressure affect your kidneys, or does it affect your kidneys in any way?
Well, there's a negative feedback on the kidneys, in that because your kidney is a filter organ, if you increase the pressure on the side of a filter, you enforce more product across there, and so you can result in proteinuria or protein appearance in your urine. Over time, when you have increased protein load in the initial urine, the kidney works harder to try to reclaim it. It's not supposed to have been filtered out, and over time that causes a condition very much like a chronic kidney disease, in that you start losing some of the filtering the epithelial cells of the kidney, and that causes interstitial fibrosis. So there's fibrosis of the kidney and immune response, and so it's kind of a feed-forward mechanism. And so those interested in hypertension, or the American Heart Association, who has graciously funded one of the projects, is very interested in the cardiorenal aspect of that, with now roughly 50% of Americans being diagnosed as hypertensive with the new guidelines. It's a major area.
So tell me about these new guidelines. Suddenly a bunch more people had high blood pressure or hypertensive?
Yeah, it's blood pressure, like many of those things, like you're getting your vitamin D measured or anything, is what the normal homeostatic level is often difficult to judge until you've sampled however many hundreds and thousands of people. And even then, is it normal or not? Americans have the worst diet than perhaps other places, or we are, different lifestyles. And so if you look at correlative evidence of co-pathologies of hypertension, including risk for stroke, chronic kidney disease, they've just pushed the guidelines down for what would be considered to be elevated blood pressure, at least. So what are the blood pressure ranges that increase your risk for these comorbidities? And that then makes roughly 50% of adults hypertensive. So it used to be about a third, which wasn't good. But then if you lower that number, now we're down to half of us. So that's all. So, okay, diet, exercise, those things are always good to maintain it. But at least for what is something to watch out for, particularly as you get older and your life and you become a little more sedentary. These are things to at least put on your radar screen.
So let's talk a little bit about renal lymphatics and the immune system, as that's part of what you're studying with the American Heart Association grant. So how does, or do we know how the role of lymphatics in the immune system? Does it increase inflammation? Or
Well, in other tissues, lymphatics are critical for the resolution of inflammation. And so when you sprain your ankle, all right, you do damage to the tissue, and the blood vasculature, the blood capillaries leak more. That's how the fluid gets there in the first place. But over a couple of days, that swelling resolves, and that is in part there's less fluid coming out of the blood vasculature, but it's because you have a functional lymphatic network there, and the lymphatics are responsible for draining that excess fluid. And they have a pretty dynamic range, and they can increase their ability to clear if you have an increased burden. In inflammation, there's an increased burden. So anytime you get a bee sting or a cut or some other bacterial infection, there is an increased load of fluid in the tissue. There's an increased immune cell accumulation in that tissue. The only route for that fluid to really be resorbed from the tissue space, and definitely the only route for the immune cells to then clear out of that tissue space, is through lymphatic vessels. And so in many preclinical models and genetic models where we can manipulate these things, models of acute and chronic inflammation, if you block the expansion of lymphatics during that process, the inflammation is prolonged. So lymphatics expand naturally during inflammation. The immune cells that come in, as well as tissue damage, secrete factors that cause an expansion of the lymphatic network. That lymphatic expansion, or lymphangiogenesis, appears to be necessary for the resolution of inflammation. Now, it could resolve over some period of time, but helping it out was part of our hypothesis. So if we augment or we increase the lymphatic density in an inflammatory event, would that help to resolve inflammation? So in the kidneys, most of the kidney tissue does not have a lymphatic vessel network. The lymphatics are in the kidney are, for the most part, track along the larger arteries and arterioles of the kidney. So we call it the interlobular arteries in the corticomedullary junction. So fluid balance in the kidney is a little bit strange because, compared to other tissues, just because you're creating urine. So if you increase the hydrostatic or the fluid pressure forces in it, you kind of force some of that fluid to go into the urine, and the kidney functions differently. The kidney is also odd in that it wants to concentrate solutes. So the salt that you eat gets concentrated in the tissue space of the kidney. That allows the kidney to work less to resorb water. So you want to maintain your water balance. And so having a high salt content in the tissue allows some of the water to just effectively suck back out of the urine to concentrate your urine. So that's part why they don't have lymphatics. But that leads the kidney highly susceptible to prolonged inflammation, because immune cells can accumulate, which has been shown in hypertension.
Tell me a little about your preclinical models to study this inflammation in the kidneys.
So our labs, as well as others, have identified that in preclinical models of hypertension that there is immune cell accumulation in the kidney. Various other laboratories have tackled this by targeting one of the immune cell populations, so targeting the macrophage population or targeting a T cell population. And they've demonstrated pretty consistently across the board that using these anti-immune therapies, that hypertension in these models is reduced. And so that's tackling, again, that immune accumulation aspect of inflammation. But the role of the lymphatics is to help clear those immune cells. And so getting tissue sections, actually this is how the studies originally started, from these various labs that had these models, we labeled them for markers of lymphatic endothelial cells or lymphatic vessels, and we were able to quantify that lymphatic density was increased in these inflammatory hypertensive events. So my laboratory had developed a model in which we can increase the lymphatic density significantly, far beyond what happens biologically. And so we tested that model in 2 different types of hypertension, one that's just simply a drug-induced and one that's a high-sodium diet-induced. And in both models, they were highly resistant to increased blood pressure. So literally 20, 30 millimeters of mercury less than their same controls.
So would this have implications for new drugs for humans eventually down the line?
Well, targeting lymphatic vasculature has been a dream of the labs that first identified the growth factors that regulate it. It's been tried, and it's in clinical trials in a few conditions. Most notably, there seems to be an effect on during heart attack, so myocardial infarction, the damaged tissue of the heart. And so there are some clinical trials in Finland using an adenoviral delivery of a lymphatic growth factor so that the heart would express a lymphatic growth factor is being applied in those models. Preclinical models, it seems to work out very well. The most noteworthy condition in the United States and in the Western world where lymphatic expansion seems to be necessary is in the case of lymphedema. So in breast cancer patients often have the sentinel lymph nodes, the axillary lymph nodes from the armpit removed. That lymph nodectomy disrupts the lymphatic architecture, and roughly a third of 20 to 30% of women who have the lymph nodes removed experience lymphedema in their arm, so the swelling of the arm. It can be shortly after surgery, it can be years following the surgery. Sometimes it's anecdotally associated with scratch, some inflammation in the tissue, but the lymphatic insufficiency in that tissue then leads to swelling over time. That limb is more prone to inflammation and infection because immune cells cannot clear from the tissue correctly. And so in that case, one of the therapies they are trying is to regrow that lymphatic tree. That's mostly through a stem cell-like transplant or a transplant of a lymph node from another place in the body to try to provide lymphatic endothelial cells to grow. The growth factor therapies there have not, to date, been tried, I don't believe, in humans. And for the kidney, and for targeting this for blood pressure, I myself am very interested in renal lymphatic density as being an indicator of susceptibility to these things. So could we use it as a biomarker? The nephrology community has long sought for some type of a urinary biomarker or a biomarker to dictate who progresses from acute kidney injury onto chronic kidney disease. It seems to happen if you suffer an acute kidney injury, you are multiple-fold likely to have chronic kidney disease longer term. Is the lymphatic density and how that inflammation resolves somehow regulate that? For hypertension, we are developing some, believe it's part of at least one of the grant aims that to develop some, in collaboration with the College of Pharmacy, some type of delivery method to increase them pharmacologically.
So how did you get involved in all of this? I mean, a lot of times a researcher will say, well, I had a family member who suffered from something, or what drew your interest to this particular subject?
Hypertension or lymphatic
physiology? Either one.
So lymphatic physiology, that's a longer story, but that's essentially one. I joined for my doctoral studies. I started at Northwestern University in Melody Swartz's lab. I wanted to work in her laboratory. She was a young and up-and-coming scientist at the time. And just by serendipity, I suppose, I had worked with preclinical models before. And so as a new graduate student, having experience with that, she just said, hey, we have this project on lymphangiogenesis, or the growth of new lymphatic vessels. I'm following a wound healing response. Would you be interested in taking this on? That wasn't the reason why I joined the lab, but that project seemed like it was bearing the most fruit at the time. So as the new student in the group, I said, sure, let's do that. And at the time, the lymphatic research community was kind of new. It had long been sort of the realm of lymphology, is what it's called, is those who study or treat lymphatic diseases, was kind of a small specialty in the medical community. And it wasn't until the late 90s, early 2000s when specific proteins that labeled lymphatic endothelial cells were identified. and the growth factors that caused lymphatic expansion were identified. And so really that was 2000, I'm dating myself, 2003 when I joined the lab, this was a new thing. And so a lot of these antibodies weren't even commercially available yet. You would get them from the labs that had generated them, but the lymphatic research was really able to take off and expand. And so people have been doing, folks like particularly here at Texas A&M, historically it was very strong in the physiology of the system, but it was really the identification of these markers that allowed the biology of the cells and of the lymphatic vasculature to really be studied. And so I was in some ways an early person in the field. Like I was a graduate student, but there weren't that many faculty in it. And so many of us who were graduate students or postdocs at the time now have laboratories that are based on lymphatic vessel research. So it was kind of a new field, but was able to carve my own, I guess, spot in it as far as lymphangiogenesis. And so one of my goals in the last decade or so was to develop models in which we could manipulate the biology of the lymphatic system to study how that impacted their function. And so we developed a model where we could expand the lymphatic vasculature. It's dictated on a lymphatic-specific growth factor, and we have targeted that in the lung, in adipose tissue for metabolic syndrome, and in the kidney. And when we first developed the kidney model, we almost knew right away that it was going to have a blood pressure phenotype because it seemed pretty clear just from the phenotype of the animals. So once I started at Texas A&M, Dr. Mitchell's lab had been studying hypertension for years. He had recently joined our department through a merger with another department, and our Department of Medical Physiology has long been a lymphatic research. In fact, when I started my graduate studies, I met many of the other faculty here, Drs. Muthachami, Zavea, and Gashev, as like early mentors in the field. They were all nice people. So strangely, over 15 years later, I then joined the department. So Dr. Mitchell kind of was, once joining medical physiology, was like, Brett, you should look at lymphatics, was basically what a lot of the folks were saying. Like, you're looking at inflammatory hypertension. Dr. Mitchell had already been studying inflammation in the context of preeclampsia and in these other hypertensive models. And so let's look at lymphatics. And so pretty much from day one when I started, it's like, I have a model that is going to have a hypertensive phenotype or a phenotype in blood pressure, so let's look at that. And then we started accumulating these sections and tissues from other researchers to look at their models as well. So lymphatics, one of the interesting aspects of them, because they regulate the immune system. So it's not just passive immune cell transport. Immune cells enter lymphatic capillaries in the periphery, and they travel downstream to a lymph node that's draining that tissue, and an immune response is mounted. So immunologists long thought of the lymphatics as this passive sewer system that essentially existed for immune cells to traffic. Studies over the last 15 years from my doctoral lab, as well as many others, have found that it's not just immune cell trafficking. So if you get your flu vaccine, you have that antigen, or what has been put in for your vaccination, that travels with the fluid downstream to the lymph node. Gets taken up by an antigen-presenting cell, which presents to the B and T cells to have a specific response against that antigen. But there's also antigen-presenting cells in the periphery that take that up locally and migrate down. But more work has been showing that the lymphatic endothelial cells themselves are able to perhaps take up that antigen and present it to immune cells. And so they're playing an active role. It's not just the walls of a pipe anymore, is that the pipe is actively sampling what's going on. And that the interaction of lymphatic endothelial cells with antigen-presenting cells or T cells can regulate their maturity and their function both in the periphery as well as the lymph node. So having a lymphatic vascular network in a tissue appears to help regulate its immunity. And so in conditions of autoimmunity, lymphatic vasculature seems to play a pretty critical role. So we had published years ago that in a model where lymphatic vasculature was lacking in the skin, that autoantibodies against its own skin were actually generated over time. So every time you have tissue remodeling processes, your own self-antigen or proteins from yourself are trafficking, being taken up by these cells and being sampled by the lymphatics. And that is then regulated to identify to not attack self. So in conditions of autoimmunity, so you could consider something like psoriasis or lupus or perhaps even multiple sclerosis, the role that lymphatics play in regulating that immune response is becoming increasingly important. And so the kidney is one of my interests as well. Is the kidney is an organ that is highly susceptible to autoimmune disease. I believe that's in part because there is not a dense lymphatic network in the tissue otherwise. So due to its physiologic roles, it lacks the lymphatics, but that sets it up for IgA nephropathy, lupus nephritis, and also then it's critically important for renal transplant rejection.
What is the coolest part of your research? What gets you excited in the morning?
I think what's always most interesting to that, in that for me, is the translatability of the condition. So I started studying the kidney years ago during my postdoc to look at like mineral balance in the kidney. So just learning how the kidney functions and how that impacts health and disease, and then what role my research plays in that. So studying the lymphatic vasculature and really gaining a new appreciation or a new understanding of what may be happening in chronic kidney disease. In a way, and the way that we're targeting this is an angle that clinicians really haven't thought about, and even the research community hasn't really thought about. And so to kind of, it's always nice to be able to do and try new things, but that the research is actually, when you find something and your result has an immediate, like, oh, I could see how this would impact a patient, is something that's always fun to have. And so it's always great when the experiment works, but when it working has an obvious implication, I guess, is the most exciting part of the work.
So tell me a little bit about what you and your lab will be doing for these grants.
So far to date, we've been able to demonstrate that during inflammatory hypertension, there is a small but significant increase in the native lymphatic vasculature of the kidney. We've been able to demonstrate that if we significantly enhance this, it's actually increasing it multiple fold, that in the models they're resistant to hypertension. And so far we've tested that in models that are somewhat artificial, but one of them is a sodium or a high salt induced hypertension. So with that as our base data, so we're pretty confident that it'll work, but we want to demonstrate it in a few other models. And so that is part of the proposed research going forward. So we have a few preclinical models that are genetically predisposed to hypertension, in which we'll be testing this out. We were just recently discussing yesterday that we're going to be starting a sort of American diet-induced model of it, so a high-fat diet feeding. So with obesity, that causes hypertension. So that's obviously a very relevant translational model. So if it works there, but in each of these models, we are concurrently testing whether or not there is changes in the native vasculature as well, within the hope of augmenting or to do to block it as well, to more convincingly show that you need to have some degree of expansion, and that increasing this will be helpful. Other goals of the grants are to characterize better how the immunology is affected, what immune cells specifically are we increasing the trafficking of and what role they play, and then also how hypertension or some causes of hypertension, such as high sodium, directly impact the biology of the native lymphatic vasculature of the kidney. So are they functioning normally under these conditions? And so some of the kidney regulatory hormones that regulate the blood vasculature and regulating blood pressure, do they also impact the lymphatic vasculature as well and regulate lymphatic vessel contractility and function? Those are some of the planned studies in a very general overview sort of way.
Interesting. I'm not sure we really talked about how blood vessels and lymphatic vessels interact throughout the body.
So in vascularized tissues, a fraction of the fluid from within the blood exits the blood. We say the term is extravasation. That is, you can think of it as almost filtration, but it's caused by the pressure difference between the blood and the tissue space. So there's a pressure driving force for fluid transfer. So that's your typical filtration that you would think of forcing water through a filter membrane. But there's also an osmolarity difference. And so if the salt concentration is higher or greater one way, you'll force both salt or water has to exchange. And so that works that way with most proteins. So the interstitial space, or the space that is within the actual tissue itself. So if you think of your muscle. So once you're outside the blood vasculature, you're in the interstitial space. And most cells of the body exist in an interstitial space. So all of their everything from their oxygen to all of the nutrients that they receive leave the blood this way. The lymphatic vessels in vascularized tissue are responsible for then clearing that excess fluid to maintain that fluid balance. And so they maintain the driving force. If you cut the lymphatics off, as is the case with lymphedema, the tissue will swell because there's no way to remove that fluid. It's also the way that the immune cells, which leave the blood vasculature, return back to circulation or move downstream to the lymph node. So many factors that influence the blood side also impact the lymphatic side as well. So if you were to look at lymphatic function or how well lymphatics are draining fluid, it is in part due to the amount of fluid leaving the blood vasculature as well. So it closes a circulatory loop, basically. So you have liters a day of lymph are generated. It's not as much as the blood, but it's really responsible for maintaining your tissue homeostasis.
So you had mentioned lymphedema as a problem in breast cancer. Why is that?
Well, so I had said before about the time when we were able to identify markers for the lymphatic system. And so oncologists had long known that lymph node metastases were a problem, and that was very indicative of an advancing cancer. And so with now these lymphatic markers in hand, pathologists were able to label tissue sections and identify that, in fact, lymphatic expansion or tumor lymphangiogenesis was highly predictive of downstream lymphatic metastases. And so one of the identification of the growth factors that led to lymphatic expansion was really based on, in the early 2000s, the tumor biology at the time. And so trials were in place, I think, to block lymphatic expansion as a means to inhibit metastases, but unfortunately they never really panned out as well in the human studies as they did in the preclinical models. Probably in large part that once the tumor advances to a certain point, there's a whole host of growth factors. So much like blocking the blood angiogenesis with the bevacizumab, which is used in breast cancer and colon cancer, and there's only a limited efficacy once the tumor is advanced to a certain point, that you're not going to stop the process.
And lymph nodes can also be used to determine whether a cancer is metastasized?
Yeah, so they'll biopsy the lymph nodes to look for tumor cells that have progressed downstream. And so in order to do that, a good surgeon so part of the problem in breast cancer was they know where they are, but humans have a network of lymph nodes. So it's not just one lymph node. So they'll often take out multiple lymph nodes in order to be sure that they got any potentially metastasizing cells. In order to do that, you can identify them, you can see them fine, but sometimes surgeons will inject a dye or some type of a contrast agent near the site of the tumor and watch where the dye flows and then identify those lymph nodes.
And then they can remove just those lymph nodes that the dye
Yeah, that's the idea. And so one of the best, most effective treatments for lymphedema is really to minimize the lymphatic destruction that occurs during the time of the initial surgery. And so they go like lymph node sparing is the idea. And so try to minimize what is taken will reduce the likelihood that lymphedema will develop in the future.
Are there any treatments if lymphedema does develop?
Most treatments for lymphedema right now are treating the symptoms. And so that is compression. So patients wear a compression garment. Massage, we call it deep decongestive therapy, and so you get it's a very thorough massage, not just like what you'd go to the spa for, to really help to move the interstitial fluid. So absent the lymphatics, you have to manually try to remove the fluid, and so it's literally forcing with, it's very much like a deep tissue massage to try to move the fluid from the affected limb. That and compression and anti-inflammatories are right now in trials to help to reduce the inflammation in the tissue. But there's currently no cure per se for it. It's just prevention is the best way.
So all you can do is try to minimize the number of lymph nodes you have to
Yeah, like
take
I
out.
said, it's a lymph node transfer has been tried and is an accepted therapy. There was a panel on lymphedema treatment probably about 6 months ago or so, and part of the recommendations are, of course, prevent it in the first place by using surgical intervention as minimally as possible. But the subsequent treatments for it are really limited to kind of experimental lymph node transfer. There's a lymphovenous anastomoses where small lymphatic vessels can be tied into smaller veins to help to drain the fluid. You're limited there due to the pressure differences in the system, and so you can't put into a larger vein because the venous pressure would be too high and cause backflow. You don't want blood backflow into the tissue. But that does work in limited cases, so not in advanced. And then, unfortunately, for cosmetic therapy, that's really only a liposuction and a tissue resection. And so adipose tissue or fat tissue expansion is characteristic of lymphedema. The only real way to resolve that is to just surgically remove the tissue. So we want to prevent it as much as possible.
Well, thank you so much for joining us today, Dr. Rutkowski, and congratulations again on these grants, and best of luck in your future research.
Thank you. It was nice to talk about our work. It's always great to have people interested in lymphatics.
And thanks for listening, and we'll see you next time.
Thank you for joining us on Texas A&M Health Talk, a production of the Texas A&M University Health Science Center. Visit us on the web at vitalrecord.tamhsc.edu, where you'll find answers to all of your health questions. Until next time, stay healthy.